Hi, everyone. Welcome. My name is Marcela, and I'm a doctor from Brazil applying to internal medicine this med season. And I'm so happy to be here to facilitate another subspecialty case discussion. And this time, we have some amazing guests to discuss an infectious disease case. So first, let's go for some introductions. Our case presenter for today is Dr. Anamaria Dragan. She was born in Romania and spent her childhood in California and finished growing up in Texas, which she currently calls her home. She's now a PGY2 in internal medicine at Emory University, and she's passionate about medical education and clinical reasoning. In her free time, she loves to cook, sing, and play board games. So welcome, Anamaria. Could you please share with us what you like the most in clinical reasoning and medical education? And you also mentioned that you like board games. Which one's your favorite right now?
Hey, thank you for that wonderful introduction. I'm very happy to be here. As far as medical education and clinical reasoning, I just think it's like pretty much the root of being a clinician. And so I think it's really easy to just go through our days, sort of getting notes done and like talking to people and kind of going through check boxes. But I think really the root and what I'm very excited about is actually learning and learning things in a systematic way, applying clinical reasoning skills, and then teaching those around us how to actually go through these things. So it makes me really happy to do those kind of as part of my job. And as far as board games, that's a loaded question. My boyfriend and I just went through and cataloged all of ours, and it's a whopping 150 that we own. So it started out as a pandemic, like sort of hobby, and it just kind of exploded from there. So it's really hard to pin down one. We play a lot, so it's a very fun hobby. It also, like, you also do reasoning like with board games too, so it's kind of hand in hand.
Oh my God, I love that. So many games. I have like a small collection of 10 games, and I think I have a lot, but whoa, that's amazing. Thank you so much for sharing. And we also have our case discussion for today, Dr. Vivek Beechar. He's a second-year infectious disease fellow interested in transplant ID. His research interests are in CMV and CMV-specific immunity in renal transplant patients. So welcome, Vivek. I was wondering if you could share with us why did you choose ID and what do you like to do on your free time?
So why did I pick ID? I think when I was in residency, I felt like the most interesting cases that we heard during internal medicine morning report were all ID cases. I think, as a percentage, I think I tabulated it. It was close to like 30 to 40%. So by default, it seemed to, at least to me and the rest of my residency cohort, to be the most interesting cases to present at morning report. In ID, I feel like, as you guys sort of insinuated with this case, each infection can present in a multitude of different ways. So I feel like it's very hard to get bored in ID. Things I like doing outside of work, I like going to the gym. I watch my football team, Arsenal, every weekend. And this season we're doing phenomenally well, so it's been a good year. And yeah, that's about it. I'm about to run the Atlanta half marathon this weekend, so looking forward to that.
Oh, that's amazing. Thank you so much for sharing. And our specialist guest for today is Dr. Varun Phadke. Dr. Phadke is a clinician educator and a faculty member in the Division of Infectious Disease at Emory University. He earned his medical degree from Harvard Medical School, then completed his internal medicine residency at Columbia University Medical Center in New York. Then his fellowship in infectious disease at Emory University. His passion is teaching and assessing clinical reasoning and decision-making skills. And in 2021, he was named Assistant Vice Chair of Education for Clinical Reasoning in the Department of Medicine. In his free time, he loves cooking, which also means eating, reading mystery novels, and spending time with his wife and his 4-year-old son. So thank you so much for being here, Varun. Could you share with us why did you choose ID? And since you mentioned that you like to cook, what is your favorite food to cook?
Yeah, absolutely. So I chose ID for a lot of the same reasons that Vivek described. I think there's always a like diagnostic mystery puzzle solving element to cases in infectious diseases. We're always asking why questions, why did this infection happen to this patient? Why is this group of patients experiencing the same infection? Why is this therapy not working? I think we always are asking the question beyond the question that we were maybe initially posed to answer. And I think that is sort of like a perpetual cognitive challenge in infectious diseases, which Vivek has sort of alluded to, which I love. I love learning something new every single day. In terms of your second question about what I like to cook, so I like to experiment in a lot of different cuisines. I most recently have been kind of cooking my way through like a Mediterranean cookbook that one of my good friends gifted to me. So that's where I am right now, but I also like to dabble in Italian food and Indian food too.
Oh, that sounds wonderful. Thank you so much for sharing with us. So I think we're finally ready for the case. So Anamaria, the mic is yours.
Thank you. So I'll introduce kind of our patient here. She is a 35-year-old female who was recently diagnosed with B-cell acute lymphoblastic leukemia. And she was actually transferred to our institution from an outside hospital for further evaluation and management of neutropenic fever and worsening dyspnea. Prior to her arrival at the outside hospital, she had developed worsening shortness of breath shortly after completing her last infusion of vincristine as an outpatient. At that time, when she was admitted to the outside hospital, she was tachycardic, she was febrile, found to be pancytopenic with a low absolute neutrophil count. During her time at the outside hospital, she was experiencing worsening dyspnea, nausea, vomiting, diarrhea, and right-sided pleuritic chest pain. She continued to fever daily despite a negative initial infectious workup and treatment with broad-spectrum antibiotics.
Okay, so the diagnosis of B-cell acute lymphoblastic leukemia, what was the time course in between when she was diagnosed to when she's presenting now to you? How long has it been?
I think it was pretty recent. I think it was within the last like 6 to 8 months or so. Got it.
And you had mentioned her chemotherapy that she was currently on. Can you say that again? I don't see that it was. Is it just vincristine or what else was?
So I think she most recently, prior to her admission, she was on vincristine. She had previously also been on methotrexate, but that was discontinued due to neurotoxicity.
Got it. Okay. So yeah, I think I'll start with very broad differential and sort of thoughts regarding what this patient's net state of immunosuppression is. So she's coming in with ALL. And so Dr. Phadke has taught us where to sort of put these patients in terms of their primary immune defect. So for this patient, I would say that they're more in the cell-mediated immune defect. And so the sort of infections that these patients are predisposed to include bacterial infections that you would see in otherwise immunocompetent patients. But also you'd have to keep viral infections on your differential as well. What time of the year was this?
Oh God, I have to remember when I was on ICU. It was like fall time. Okay.
So yeah, I think that's helpful as well, knowing the time of the year, just in terms of the viral differential, because it sounds like she's coming in with dyspnea, sort of right-sided pleuritic chest pain. And then there's also, viral infections that, may reactivate in the setting of someone having depressed cell-mediated immunity. So things like CMV can sort of pop up in these sorts of situations. I don't really think, depending on where she's been and how long she's been neutropenic, you do have to consider fungal infections as well. And as we get more history from her, we can sort of differentiate from her having maybe an endemic fungal infection versus something that her febrile neutropenia could predispose her to. The other thing that I'd like to know is how long she's been neutropenic for. So if she's been neutropenic, and I think you mentioned she had been on antibiotics and was still fevering. If she has been on antibiotics, for 7-10 days and still fevering, I think my differential for her having an invasive fungal infection starts to go up. And so, putting her on antifungals at some point in time would also be something that I would consider doing. But that's sort of where I'd start with.
Oh, thank you so much, Vivek. That was amazing. Dr. Varun, I was wondering if you could share with us some teaching points. I noticed that Vivek in the beginning, he asked about the time and some questions about the chemo, the host, and he mentioned the net state of immunosuppression. So if you could share why is this important for ID?
Yeah, absolutely. So, I think it's going to be hard for me to add to what Vivek already said, but I think what he's sort of articulating is recognizing the fact that neutropenic fever is a very generic syndrome that encapsulates a lot of unstated information about the host, because patients can be neutropenic for a variety of reasons. And so it's important whenever you're approaching an immunocompromised host to sort of think about, is their neutropenic fever related to their underlying disease? Like, do they have a myeloid malignancy, for example, like AML or CML? Is their neutropenia because they've received cytotoxic chemotherapy for that malignancy, as might be the case in this patient who actually has a lymphoid cancer but has received chemotherapy that's made her neutropenic? So it's essentially drug-induced neutropenia, because not necessarily because those two entities, like the neutropenia that's resulting from those two entities is categorically different, but the duration of neutropenia, as Vivek was alluding to, is important because that can influence your risk of specific types of infections. So we think of the infections associated with neutropenia as being like extracellular organisms, like extracellular bacteria or extracellular fungi, like molds. And if the person has been neutropenic for a long period of time, our consideration of those entities goes up. Whereas if they've been neutropenic for a shorter period of time, then we're wondering less about, let's say, invasive mold infections and more infections related to the original source of their hematologic problem, which is in this case the ALL. So that's sort of how I think about neutropenia, is thinking about, is the neutropenia a result of the host's sort of underlying disease, or is the neutropenia the result of the therapy we've given the patient, and use that to sort of judge how long they've been neutropenic.
Anamaria, I think we are ready for the next aliquot.
Okay, sounds good. Do you want me to go through her past medical history, family history, and social history?
Yes, sure.
So her past medical history is really just this ALL that she was diagnosed like around 8 months ago. Like I said, she had methotrexate related neurotoxicity as a result of this. And interestingly enough, she has had several prior admissions for neutropenic fever during the course of her disease. And once again, during all of those hospitalizations, her infectious workup remained negative. And ultimately, her fevers kind of resolved on their own, and she was discharged home each time. She also had a history of spontaneous abortion, but otherwise she was previously healthy before this diagnosis. As far as family history, there wasn't really anything significant, and she has no family history of malignancies. For social history, she lives with her husband, who was recently working hurricane relief in Florida. She worked as a wedding planner prior to her leukemia diagnosis. At the time of her admission, she was not vaccinated for COVID, and she didn't have any known exposures like to pets or other kinds of, environmental exposures. No smoking, alcohol, or drug use. As far as the medications that she was on prophylactic valacyclovir, fluconazole, and levofloxacin, as well as Bactrim. And then she was on other kind of management meds. She was on baclofen, lorazepam, and Zofran, as well as oxycodone for kind of cancer-related pain.
Okay, so Vivek, how does that exposure history and medication change your differential?
Yeah, so I don't think, the social history per se changes much for me. I mean, the fact that she's unvaccinated for COVID-19, obviously COVID-19 should be on the differential with someone coming in with worsening dyspnea, whether it would cause, yeah, I think it should definitely be on your differential, and she probably got swabbed for COVID even before she got to the floor of the ICU. I don't think anything else, she doesn't really have a travel history, and her husband working in Florida for hurricane relief doesn't sound like she was there. Regarding the past medical history, it doesn't surprise me that her ID workup was negative for neutropenic fever in the past. Oftentimes these people will come in and they'll get blood cultures, and we don't end up finding what caused them to have the fever in the first place. And then regarding her, I think the thing that's probably most informative is what sort of medications she's been taking prior to coming in. So the valacyclovir, is going to hopefully prevent her from getting HSV or VZV, but obviously, depending on how consistently she was taking it, that would be a consideration. The Bactrim is being used for pneumocystis prophylaxis. So someone coming in with fevers and dyspnea, and usually it's more of an exertional dyspnea, and it can present, more insidiously in patients outside of our patients living with HIV. But if she's been taking Bactrim, then I think that makes that a little lower on the differential for her current presentation. And then the levofloxacin, she's probably prescribed that for the purpose of preventing invasive bacterial infections, usually translocation from the gut. And then the fluconazole, the important thing to note for that is that fluconazole is great for sort of candidal prophylaxis, but it doesn't have any mold coverage. And so that's something to keep in mind as we sort of go further in the story and see how long she's been neutropenic during this admission. And let's see, family history, there was nothing. And then, yeah, it didn't sound like there was any health related behaviors. The other thing always to keep in mind is sort of drug toxicities. But it sounds like she's been off the methotrexate. Usually I think of more of, it causing liver issues, but there's always some of these chemotherapeutic drugs, more so bleomycin, but that can cause sort of like a respiratory pneumonitis as well. But I don't think that's high on my differential based on the drugs she's currently taking or has received recently.
Oh, thank you so much. Varun, I was wondering for us learners, when you have a patient like this that is immunosuppressed, and you go see the patient, what is important for ID exposure history for us to ask? And also in the physical exam, what should we look for, active look for?
Yeah, that's a great question. And part of it is shaped by, I think, what you think the syndrome might be, which is hard because when you are neutropenic, you may mount less prominent localizing symptoms because a lot of the localizing symptoms of infection that we're used to in immunocompetent individuals are because of the immune response, like neutrophilic infiltration into the lungs or the meninges or urinary tract. All of that inflammation is what causes symptoms. But if you have an absence of neutrophils, you may not have localizing symptoms. But if you have localizing symptoms, like we seem to in this case, which is primarily a respiratory type syndrome, I think the kinds of exposures that you're going to chase after would be person-to-person transmitted organisms, so asking about sick contacts, and sort of the vaccination history that Vivek was getting at with COVID-19. In this person who's got a B-cell malignancy, she may be at risk, for example, for a protracted illness due to COVID-19. You might also ask about respiratory pathogens that can be acquired from the environment, and so like fungal organisms. You might ask about recent exposure to construction or outdoor hiking where they were exposed to aerosolized soil. That would sort of invoke certain fungal pathogens as well as things like nocardia, and then exposure to animals. It's important to take that history carefully because oftentimes this happened to me a lot, where if you ask someone, if they have any pets, they might answer no, but that's because they don't consider the animals that they are in regular contact with as their pets. And so you have to be very sort of open to asking people like a very generic question, like, have you been exposed to any animals inside your home or outside of your home that may or may not belong to you? And recognizing that people may not, feel like the animals that live outside their home are their pets, or even the animals that their partner that they live with are not their pets, or that an animal that lives outside their home but not inside their home is their pet. So just be cognizant of that. Other syndromes would provoke other exposure histories, right? So if it's a gastrointestinal syndrome, you might think about ingestions and water exposure and travel and things like that. A cutaneous syndrome, you might think about sort of cutaneous inoculation and things like that. So on physical exam, you have to be very attentive to subtle signs of infection because the patient may not have a prominent sort of finding just because of the absence of neutrophils. So doing a careful skin exam to look for sites of dissemination of bacterial, viral, fungal infection, being very attentive to the oral cavity to look for signs of candidal infection or oral ulcers that might indicate an invasive fungal infection or viral infection. Obviously, a careful pulmonary exam, especially in a patient with respiratory symptoms. Though honestly, the respiratory exam and even chest X-ray have poor sensitivity in a patient who is profoundly neutropenic. Those are sorts of the sorts of things to sort of be very attentive to, and just be like humble about the fact that in patients with neutropenia, the physical exam can be not very sensitive for very severe infections.
Well, thank you so much. That was an amazing teaching point. Anamaria, please tell us more.
Sure. So going into her vitals on admission, her blood pressure was 111/67. Her heart rate was 134. Her temp was 37.8 Celsius. Her respiratory rate was 32, and she was satting 94% on 2 liters of nasal cannula. For her physical exam, in general, she was awake, alert, and appeared to be in mild distress. She had normal conjunctiva. Her pupils were equal, round, reactive to light, and she had dry mucous membranes. For cardiovascular, she was tachycardic, but had a regular rhythm, and no murmurs were appreciated on exam. For pulmonary, she had bibasilar crackles. She had decreased lung sounds in the bilateral bases, and she was tachypnic. Her abdomen was soft, non-tender, non-distended. Her extremities, there was no edema. She had normal range of motion. Her skin was warm, dry, and there were no lesions or rashes or any thing noted on her skin. For neuro, there were no focal deficits. And for psych, she was pretty anxious and tearful throughout the exam. For her initial basic labs, her sodium was 140. Her potassium was 3.9. She had a chloride of 107, a bicarb of 28. BUN was 4. Creatinine was 0.38. Her AST and ALT were normal. Her ALP or alk-phos was 110, T-billy of 1.2. Her white blood cell count was 0.1. Her hemoglobin was 7.3 with a hematocrit of 20.5. Platelets were 79. And that's all I got. Oh, and her absolute neutrophil count was low.
Vivek, how does this physical exam and initial labs help you on your diagnosis?
Sure. So just starting from the top, I mean, she's fairly tachycardic, a heart rate of 134. She's breathing pretty quickly, 32 times a minute. But in terms of her oxygen requirements, they're not high right now, but that could obviously change with time. Her physical exam, nothing is very revealing here. On her lung exam, she has decreased lung sounds at the bilateral bases. I mean, that could potentially indicate maybe some pleural effusions. We'll see what her imaging shows, because I do think a CT scan of her chest is going to be pretty informative here. And then I'm not really getting anything else other than, maybe she's a little volume down, but that's pretty much it. In terms of her labs, her bicarb is 28, so she doesn't appear to have like a overwhelming lactic acidosis here. It seems that whatever is driving her, her respiratory rate to be 32, she's not necessarily compensating for something. It's more so that maybe she's got maybe a parenchymal lung process that's going on. The other things that her labs show, her LFTs are normal. Maybe her alk-phos is a little elevated, but that's, it's not really helpful there. Is her albumin really 7.3, or was that a typo?
Her hemoglobin is 7.3.
Hemoglobin is 7.3. Okay, thank you. And then in terms of her CBC, I mean, I think that this was already hinted at. She has neutropenia. I mean, her ANC is likely less than 500, and then she's pancytopenic, likely from her underlying malignancy, plus or minus the chemotherapy agents she's getting. So that's what I'll say about that. The one thing that I didn't get to ask, and I just sort of popped up in my head now, is you mentioned that she had diarrhea. What was the time course for that? And was she still having it when you guys saw her initially?
Yeah, that's a great question. I think by the time she arrived at our institution, her diarrhea had largely resolved, but they went through kind of a full workup for that at the outside hospital.
Got it. Yeah. So just the sort of diarrhea and respiratory symptoms, that it sort of fits with a viral process, at least based on the fact that it's sort of two organ systems that seem to be involved here. But I think her CT scan of the chest will also help sort of piece apart which sort of direction we're going to go. And then how many days of neutropenia has it been? I'm sorry, I don't know if you had mentioned that just as yet.
Ooh, I do not know the exact day count, but
Okay.
I think she was at the outside hospital for a week at least prior to coming here.
And had been on antibiotics for a week.
Correct, at least.
Okay. All right. Sounds good.
Varun, I was wondering what other labs and imaging you would like to order now. And also we have a question in the chat. I read that pleural effusions are not typical for PJP. Is that correct?
Yeah, great question. So I'll address the question in the chat first, which is, and that is correct, that pleural effusions are not a characteristic radiographic abnormality associated with pneumocystis. The same can be true. The same can be said about prominent lymphadenopathy, which is uncommon with pneumocystis pneumonia. So if you see either of those findings, it should, and you're about to attribute it to PJP, you should stop and wonder if there's a second diagnosis. In terms of your question about next steps in workup, I think as Vivek has mentioned, he wants to obtain a CT scan of the chest, and I think that's a really astute recommendation, because implicit in that is the recognition that a chest X-ray is not going to be sufficiently sensitive to exclude pulmonary pathology in a patient who's this profoundly neutropenic. Now, that's very different from the patient who's neutropenic after, let's say, a round of chemotherapy for a solid cancer, like let's say a patient who is receiving cytotoxic chemotherapy for lung cancer or breast cancer. That person may be neutropenic for a few days as a result of that chemotherapy, but then their neutrophils quickly recover to normal. And in that short amount of time, they are not likely to develop an invasive fungal infection like a mold infection, for which a chest X-ray is not going to be adequate to exclude it. And so if you think about patients that you either have worked up yourself in the hospital or will work up with neutropenic fever, if it's neutropenic fever in the setting of therapy for a solid cancer, just a PA lateral chest X-ray would be totally appropriate. But in this patient, a CT scan of the chest would be absolutely necessary. And then in terms of additional laboratory workup, I'm not going to sort of suggest too many things, but I think Vivek has mentioned a lot of potential etiologies already. So he's thinking about viral diseases. Respiratory swab specimens, like a multiplex PCR-based assay to look for respiratory viruses. He's also mentioned some herpes viruses, specifically CMV, so a CMV PCR would be helpful. He's also mentioned fungal diseases, and there are fungal antigen tests that can be sent from both the blood and respiratory specimens if this patient ends up needing a bronchoscopy, as an example. So this is the kind of patient where you would spare essentially no expense in evaluating for a broad range of pathogens, and that's purely based on the severity of their immunologic defect.
Oh, thank you so much. Anamaria, please tell us more.
Yeah, so let's go through some imaging. So her initial chest X-ray showed right greater than left pleural effusions, as well as just diffuse airspace opacities. And at the outside hospital, they actually did a CTPE protocol, which demonstrated occlusive pulmonary emboli in the segmental branches of the right middle and right lower lobes, as well as scattered focal nodular and patchy ground glass opacities with smooth interlobular septal thickening and small bilateral pleural effusions. So we essentially treated her for the PEs and broadened her antimicrobial coverage to include fungal. I think we started her on amphotericin B and isovuconazole. However, her clinical picture was worsening despite all our interventions. And we actually repeated a CT chest 2 weeks later, which showed interval development of a right middle lobe cavitary lesion with an air fluid level. There was also interval worsening of a right lower lobe consolidation, actually right lower, right middle, and pretty much most of the right upper. So her entire right lung was worsening. And there was actual extension of infection through the chest wall with a 6.9 by 2.8 centimeter fluid collection between the right breast and right anterior ribs with peripheral hyperdense aspects. There was also progression of her left pleural effusion with near complete compressive atelectasis of the left lower lobe. At this point, she also had chest tubes in, which were also seen on the CT.
Wow. So that's,
Whoa.
oh, sorry.
No, go ahead.
No, that's pretty dramatic. I didn't think it was going to progress that rapidly and in that direction, based on that first CT scan. So I think, starting off with the first CT, one of the things that I learned as an ID fellow is learning how to read a CT chest is very helpful because it really is very informative for how we sort of form our differentials. So initially, you had mentioned patchy ground glass opacities, and I think you said nodular opacities as well. So when I see ground glass opacities, the things to keep on your differential at that time are things that include viral infections and things like pneumocystis. And non-infectious issues like volume overload would be something else also to keep in mind, especially with the interlobular septal thickening. But the progression from that CT to the next one, where we see a cavitary lesion that's popping up with worsening air fluid levels, I think that there is very atypical for a viral process. And things that start coming to my mind is an invasive fungal infection versus maybe a worsening bacterial infection that we're not treating with the antibiotics that we're giving. And so the thing that's worrisome though is, the extension into the chest wall. And there's a couple of things that can sort of do that. Actinomycosis tends to ignore these factual boundaries and sort of invades very aggressively. I usually, it would be very odd for her to present with that, but that is something that comes to mind when you have something that's this destructive. And then you had mentioned the antifungals that she was taking. And I think you said it was amphotericin B and isavuconazole. Is that right?
Yeah, that's correct. That's what she was started on when she presented.
So she had been on these agents and this developed on those antifungals.
Correct, yeah.
Yeah, so, the things to keep in mind there, there's certain fungal molds specifically that amphotericin B does not cover. And so molds like Scedosporium would be something to keep in mind that, it may, you may be having the patient on these very broad antifungals and the patient still, has a worsening clinical course like this patient does. There's a type of Aspergillus terreus. I think 30% of isolates are also resistant to amphotericin. So let me back up just a little bit and ask you about some of the tests that Varun had suggested, starting with, the non-invasive fungal markers, the beta-D-glucan and the Aspergillus galactomannan.
Yeah, Vivek, great question. And that's a spoiler for our next aliquot.
Oh, okay. Okay. And then I'm just to be thorough, the CMV PCR, I'm presuming that was negative. The viral respiratory panel, that those were negative as well.
Yeah, they were. I'll give you that one.
Okay. All right. Sounds good. Yeah. And in terms of where I would go from here, I would definitely try to bronch this patient, particularly if she's still on 2 liters of nasal cannula. the other thing is this sounds very invasive. So I don't know if this is surgically amenable for someone to get a sample, but I think getting tissue here is essential, and getting it to a pathologist to take a look at it as soon as we can would be something that I would be strongly advocating for. And then also considering what antifungals we're giving this patient.
Well, what an amazing discussion. Thank you. Varun, would you like to add something else?
Yeah, no, that was terrific, Vivek. I have very little to add. I guess the pearl that I'll add here is I think the two elements of the imaging findings that Vivek is picking up on are the rapidity of progression and the sort of lack of respect of this process for tissue planes. So, usual bacterial infections in the lung, like, staph, strep, gram-negative Pseudomonas, they can cause necrotizing pneumonia, but rarely do they extend beyond the pulmonary parenchyma and pleural space into the chest wall. And so there's only a small number of pathogens that we think about that do that. And Vivek mentioned one, which is actinomyces. Tuberculosis is the other one that does that among bacterial causes, and then Streptococcus aeruginosus. And then invasive fungal infections can do that as well, and many of the ones that Vivek mentioned, as well as things like Aspergillus and mucormycosis. And so if you have that relatively small list of pathogens that behaves in this way, and then you layer on the speed of progression, it sort of puts you into the category of fungal and disease, because actinomyces and TB and Streptococcus aeruginosus are usually much more indolent pathogens. And two of them, actinomyces and Streptococcus aeruginosus, really should have responded to the antimicrobials the patient's already received. So Vivek, I think, is his request for the additional testing that Anamaria is going to share with us soon, I think is on target based on what he has seen on the CT scan.
Well, thank you so much for that teaching point. Anamaria, the mic is yours.
Great. So I wanted to use this aliquot to go through basically all of her microbiological testing. So I'll just quickly run through the testing that was done prior to her admission at the outside hospital. She had several sets of negative blood cultures. She had an AFB culture that was negative. She had a pleural fluid from a thora that was negative. She had a negative urine culture. She had negative sputum cultures as well. Her Legionella urine antigen was negative. To touch on that diarrhea, she was C. diff PCR positive, but toxin negative. As far as viral studies, her CMV, HSV, RSV, flu, and COVID were negative. She was EBV positive. Her hepatitis panel was also negative. And I think that kind of goes through her initial testing. As far as a bronch, that unfortunately was delayed just due to her clinical status. There was quite some time where she was too unstable to safely do a bronch, which I think kind of delayed her diagnosis. But eventually we were able to do it. And the studies that we got from that, she had a full respiratory biofire that was negative. Cryptococcus was negative. PJP, histoplasma, and blastomyces were negative. And beta-D-glucan was negative. The Aspergillus galactomannan antigen from her BAL ended up being positive. And she had a serum galactomannan that was also positive. We were also able to get a sample from that chest wall invading mass. The cytology came back a little bit later, which actually showed under like the microscope hyphae with morphology that was concerning for mucor.
Whoa. So Vivek, what are you thinking right now?
Yeah, so the non-invasive fungal markers that you collected are actually pretty informative in this situation. But in the case of Mucor, we actually expect it to be negative for both. So that is a little surprising that you said both serum and BAL positive?
For the galactomannan, yeah.
Yeah, for the galactomannan. Yeah, so that's surprising because usually it's negative on both beta-D-glucan and galactomannan. The reason why she probably was worsening on therapy is usually when someone has invasive mucormycosis, the treatment is both surgical and medical. And so once we diagnose invasive mucor, I think the first people that we want to talk to is the surgeons to try to get this resected or try to get as much of it resected as we can. If someone has bilateral involvement of the lungs, it's a very, very poor prognostic marker because there's only so much of someone's lung that you can take out. And so I think there's a question in the chat, could the galactomannan be a false positive? It's possible. I don't know what other interventions she had been getting along the way. But yeah, that would be sort of my next steps for her. And I think she was already on amphotericin and Cresemba. So I don't know if there's much to change in terms of the antifungals. I think they need to talk to the surgeon as soon as possible.
Varun, if you could share with us some teaching points about mucormycosis.
Yeah, so this is a really challenging case because, as Vivek pointed out, there's a discordance between the non-invasive markers that we usually use to diagnose IFI, invasive fungal infection, and what we're seeing on histopathology. And the challenge is, number one, the markers themselves are imperfect. Number two, histopathology can be imperfect. And number three, we're often operating under the assumption that the patient only has one microbiologic diagnosis, but they may actually have two. And in case series of patients with invasive mucormycosis in particular, a non-trivial proportion of patients actually have dual infection with more than one fungal organism, including Aspergillus. It's very difficult to give you a sort of a generalizable statistic there because the number of such patients is small. But I think to the question that was in the chat, certainly there are causes of false positive Aspergillus galactomannan, but I think for this patient to have them positive in both sites is strongly suggestive that the patient actually does have invasive aspergillosis. And that could even be an explanation for why she had pulmonary emboli if it's angio-invasive pulmonary aspergillosis, though certainly mucor can also invade the vasculature. You asked me about mucor. I mean, I think many features of this case are consistent with mucor in terms of the progression of disease, the fact that the patient was not on any antifungal prophylaxis that would be effective against mucor, the sort of duration and depth of the patient's neutropenia are very strong risk factors for mucormycosis. And then the sort of rapidity of extension outside of the chest is very suggestive of mucormycosis. The question in the chat about effective prophylaxis for mucor. So the two drugs that are traditionally used are posaconazole and isavuconazole that Vivek just put in the chat. I think I would be curious to know what the cultures eventually yielded in this case. But as it stands, based on the data that we have, it's very possible that the patient has both infections at the same time.
Thank you. So Anamaria, we are all very curious to know, how did the patient do? What were the next steps?
Yeah, so ultimately, based on the data that we had collected thus far, the diagnosis of pulmonary mucormycosis and aspergillosis was made, complicated by empyema necessitans. At this point, as Vivek said, we consulted the surgeons for a possible right pneumonectomy and chest wall debridement. However, clinically, she was not stable for that, and she was deemed not a surgical candidate. We had been treating her with amphotericin B and isovconazole. However, numerous goals of care conversations were had with her and family. She was ultimately discharged to home hospice.
Well, thank you so much. What an amazing case and discussion. Vivek, what were your thoughts and how was the discussion for you? What did you learn from the case?
No, that was a great case. Thanks for the invitation and for presenting it. I think that it definitely, as Varun said, I think the biggest thing to learn, at least from my standpoint and what I sort of learned from this case, is the progression of her CT scans and the way that her CT findings evolved, I think, is the most informative here. And then particularly when you see something eroding into the chest wall, I think you said the CT scan said it was, invading her right breast. I think there's very few infections, as Varun had suggested, that do this. And so I think, and oftentimes in these cases, I think the delay in diagnosis can lead to suboptimal outcomes. Having a very high index of suspicion for this, particularly since she was neutropenic at the outside hospital for 7 days on broad spectrum antibiotics, that should automatically throw red flags in your mind that why is this patient who's on presumably vancomycin and meropenem still febrile 7 days after getting it. I think that's sort of the biggest teaching points, at least that I took from this case.
Oh, thank you so much. Varun, if you could please share with us any final teaching points and reflections about the case.
Yeah, this was a very challenging case. I think one of the things that is that I continue to be humbled by in the practice of transplant ID, and I know Vivek shares this sentiment given that it is his interest, is sort of how much we take for granted the normal immune response to pathogens, and when it is defective, how much presentations can be altered from our usual illness scripts, how much we have to maintain a high suspicion for things that we are otherwise used to excluding on clinical grounds alone, and remaining open to the patient having more than one diagnosis. I think that is, a perpetual challenge in transplant ID, but also one that is that challenge is often very stimulating, and I think as Vivek suggested, motivates you to try to make these diagnoses as quickly as you can to make the most impact on the patient's outcome.
Amazing. Thank you so much. Yeah, definitely transplant ID make us feel very humble. Anamaria, I'm curious to know your final thoughts and how was your experience taking care of this patient?
Yeah, so like I said, we took care of her in an ICU setting. So it was more of a team of us residents kind of cycling through her care as we were coming on and off call. So I had 2 weeks to get to know her and her family. And I think, like what was already talked about before, it was just striking at how quickly everything kind of progressed. Despite us, doing pretty much everything we could medically wise with the antibiotics and antimicrobials. And I think, like Vivek said, it was a little bit frustrating not to be able to do the diagnostic testing that I think she needed quickly enough. So I think ultimately this case was great for learning and great for really recognizing red flags and things that can be indicative of a sort of brewing underlying thing like invasive fungal infections in these types of patients. And so I think it was a little humbling to be a part of, just to really understand how crazy these things can get. And like Varun said, how happy I am that I have a working immune system.
Yes, thank you so much for sharing the case with us and your reflections. And thank you all for being here today. And now I pass the mic to Yasmin. Yasmin, if you could please introduce yourself and then finalize with your teaching points. Thank you.
Of course, thank you so much to everyone. Thank you for this humbling case, Anamaria, and thank you Vivek and Varun for this amazing discussion. I believe we all got great teaching points for this session. Now we started with the main approach of an immunocompromised patient with neutropenia, asking about the onset of the malignancy that this patient had, chemotherapy, the nature of the chemotherapy, and if that could influence in identifying this pathogen. A long treatment with antibiotics, long neutropenic state, and even fever is by itself a red flag. Why this patient with different chemotherapy and antibiotics could present this long withstanding fever. For example, the type of treatment can prevent invasive bacterial infections. In this case, Bactrim can prevent Pneumocystis cerevisiae, fluconazole versus Candida, Palaciclovir versus HSV or VZV. Now we can also ask if they receive chemotherapy or any other drug that can cause neutropenia by itself. And if there are less localizing symptoms, it's a little bit more difficult to identify. But if there are, we could ask for sick contact, vaccination history, environmental exposure, such as outdoor hiking, occupational exposure, animals. When doing the history, remember, be very open with asking about the patient exposure to avoid omission. Sometimes patients do not really recognize their own exposures. And as well, a careful skin exam can aid in finding the site of infections. Also, don't forget to look in mucosal cavities. Now, approaching to imaging tests, some imaging tests can be less sensitive than others. That's why Dr. Vivek was thinking of asking for a CT scan. There are signs and features that on imaging that can present with certain infections. For example, pleural effusions are not normally seen in Pneumocystis cerevisiae pneumonia. Now, in this case, we saw this patchy ground glass opacity that progressed to a cavitation with air fluid levels, thinking, well, this may be an invasive fungi or an actinomycosis, TB, Streptococcus aeruginosus. But again, there is a convergence with ATB these patients was already receiving. The next step was asking for a biopsy, histology, and other tests such as serum galactomannan and beta-D-glucan that could help us identify the guilty pathogen in this case. Now we got that it was mucormycosis, and the treatment is surgical and also medical. This bilateral involvement has poor prognosis, and the diagnostic challenge in mucormycosis is that, one, the markers are imperfect as well as the histology, and then these patients tend to have two microbiological diagnoses. As we saw, they also had aspergillus, so that's why it was very rare to find both tests, beta-glucan tests and galactumannan tests, positive. This prophylaxis for mucormycosis is posaconazole, Cresemba, and remember, this infection tends to progress aggressively, so the delay in diagnosis can lead to suboptimal outcomes. So these are all the teaching points for today. Thank you very much. And thank you, Dr. Vivek, Dr. Varun, Dr. Anamaria. We are very happy to have you here with us today. Back to you, Marce.
Thank you so much, Yas. Thank you so much for our guests. We had an amazing case and discussion, and I'm sure we all learned so much. So see you all later. Bye-bye.